In this presentation, we're going to review the steps of the cardiac cycle as well as learn how to construct a Wigger's diagram. We're going to begin with phase 1 of the cardiac cycle. Now note that we're going to be focusing on the left side of the heart, but we'd see similar tracings on the right side. They would just be at lower pressures. So phase 1 begins with the P wave traveling through the atria, and that will ultimately lead to contraction of the atria. Note that the mitral valve is open and the aortic valve is closed shut. Also note that the ventricle already has a substantial amount of fluid in it already, and that is from filling from prior phases. We'll return to this thought in a little bit. With the electrical signaling that travels through the atria will contract, and that will force additional blood from the atrium to the ventricle. Now, the ventricle obviously will get an increase in blood volume as blood is pushed from the atrium to the ventricle. The atrium will then relax, and note that this entire active filling process is sometimes called the atrial kick, which accounts for only 10% of the filling of the left ventricle at resting state. However, with exercise, the kick may increase up to 40%, and that is because despite the increased heart rate, which causes less time from beat to beat and therefore less time for filling and diastole, there will be an increase in sympathetic drive, which will increase the force of this atrial kick. The aorta is relatively isolated from this action, and blood is passively flowing from the aorta to the rest of the body. It's also important to note that this phase is the location of a pathological S4, and that occurs when the atrium contracts against a stiff, non-compliant ventricle, causing turbulent flow from the atrium to the ventricle. This is known as, or this can be remembered as, a stiff wall, which is the sound we would hear on auscultation versus the normal lub-dub that we otherwise hear. Going to our diagram, we'll initially have a short increase in atrial pressure. This will be known as the atrial contraction wave, or A wave. We'll then see an X descent, and that represents the atrial relaxation. We'll note a matching process in the ventricle as there's an open mitral valve between the atrium and the ventricle. We'll also see that the aorta has a gradually decrease in pressure as blood passively flows from the aorta to the rest of the body. We'll see a slight increase in LV volume, and as mentioned, this may only be 10% if the heart is in resting state. And this is also the location of the pathological S4 sound. Let's clear the slate here and move on to discuss phase 2. Now, phase 2 begins with the arrival of a QRS complex that depolarizes through the ventricles. This will cause the LV pressure to exceed the LA pressure and ensuingly slam the mitral valve shut. In addition, ventricular contraction will raise the pressure in the LV. Now, the slamming shut of the mitral valve makes the corresponding lub sound known as S1. Note that the valves are closed at both ends of the chamber, so the volume will stay the same within this chamber. This is known as isovolumetric contraction, iso meaning same, volumetric contraction. In the atrium, we'll see a bulging of the mitral valve actually into the atrium as the ventricle contracts. We'll also see passive venous return to the left atrium. These processes together will cause an increase in atrial pressure during this phase. The aorta is relatively sealed off from all of this action behind a closed aortic valve, and pressure continues to decline as blood is distributed to the body. This all corresponds to the first phase of systole. Now let's go to see how this corresponds to our Wigger's diagram. As mentioned, the mitral valve closes initially, and this gives a corresponding S1 sound. The increase that we had talked about in the atrium, which is from the bulging of the mitral valve as well as passive venous return, makes a small increase in pressure known as the C wave, C standing for contraction of the ventricle. In the left ventricle, we'll see an increase in pressure as the boundary valves on the ventricle are closed, being the mitral and aortic valves, and there's a rapid increase in ventricular pressure. Away from this action, the aortic pressure gradually decreases, and the LV volume is held constant. This is known as the left ventricular end diastolic volume, and that makes sense as diastole is now over and we are observing the LV volume during isovolumetric contraction. Let's move forward now to talk about phases 3 and 4. So in this phase, the left ventricular pressure continues to increase with ventricular contraction, ultimately to a point that it is able to overcome the pressure in the aorta, and that forces the aortic valve open. Now, with the opening of the aortic valve and continued contraction of the ventricle, we'll see blood rush from the left ventricle into the aorta. This will drive both the pressure up in the left ventricle and the aorta. Additionally, clearly the volume in the ventricle will decrease as blood is ejected out. In the atrium, we'll actually see an initial drop in pressure as the atrial base drops with the left ventricular contraction. However, we'll then see a gradual increase in atrial pressure with passive blood flow into the atrium. Now let's go ahead and draw this into our diagram. So as mentioned, the aortic valve opens up, and we'll see a pressure increase in the ventricle as it continues to contract. With this pressure increase, we will see similar pressure tracings for the left ventricle as to the aorta. We'll also see that the atria has completed its C wave and has an X prime descent, or what is known as the X prime descent, and this is where, as mentioned, the base of the atria has dropped during the ventricular contraction. We'll then see gradual filling of pressure, gradual increase of pressure in the atrium as it is passively filled by venous return. Here we will also see rapid decline in LV volume as blood has been ejected into the aorta from the left ventricle. Now let's talk about phase 4. Let's move over to the EKG. In the EKG, we'll typically see a T wave, and this represents repolarization of the ventricle during phase 4. So here the ventricle will begin to relax, and we'll see a reduced ejection phase. This will ultimately lower the left ventricular pressure, and will also lower the pressure in the aorta. The left atrium is kind of far from this action, as it is behind the closed mitral valve, so pressure will gradually be increasing as we see passive venous return from the pulmonary veins. Let's go ahead and draw these on the Wiggers diagram. So as mentioned, we will see a lowering in the left ventricular pressure. We'll similarly see a lowering in the aortic pressure, and we'll see a gradual increase in the atrial pressure. Additionally, the LV volume continues to drop, but it drops at a slower speed as the ejection speed has begun to slow down during this phase. Now let's go ahead and talk about phase 5. In this phase, the ventricles continue to relax, and the intraventricular pressure continues to fall to a point where the total energy of blood within the ventricle is less than the energy of the blood in the outflow tracts. This will ultimately cause the aortic valve to shut. This gives also the characteristic S2 sound, or dub in lub dub that we hear on auscultation. It also marks the end of systole. Now, as mentioned, we will see a rapid relaxation of the left ventricle during this phase. We'll also note that the valves are closed at either end of the chamber, and so volume within the chamber will stay the same. This is known as isovolumetric relaxation. In the aorta, we actually don't see as quickly of a drop in the pressure as potential energy is stored within the elastic walls of the aorta. In addition, there's also resistance in the systemic outflow, and that will impede the flow of blood distributing into the arteries of the systemic circulation. Thus, there's a transient increase in pressure in the aorta. Now, the atrium is closed off from the ventricular action by the closed mitral valve and continues to receive venous return. Now, going back to our diagram, as mentioned, the ventricle now has less energy than its outflow tract, so we will see that the aortic valve will close. We'll also see the corresponding S2, or the dub sound at this point. We'll see a rapid drop in LV pressure as the ventricle relaxes, and we'll see a notch, or incisura, as it's also known, in the aortic pressure from its elastic recoil and high downstream resistance. We'll also see a gradual increase in atrial pressure, and that is designated with the V for venous filling of the atrium, which makes sense as this gradual progression in the atrial pressure has been governed by venous return to the atrium. Now, as this is isovolumetric relaxation, the volume within the left ventricle will stay the same as it was at the end of systole, and that is known as the left ventricular end systolic volume. Let's now talk about the final two phases, phases 6 and 7. Here the ventricular relaxation continues to a point where the ventricular pressure drops below the atrial pressure, and ultimately the mitral valve will open. This will cause blood to flow across the valve from the atrium into the ventricle. Note that this is a passive flow and that the atrium is not actively squeezing. This movement of blood from the atrium to the ventricle will cause a drop initially in atrial pressure. However, with passive venous return, we'll see that it ultimately becomes gradual increase in atrial pressure. The ventricular pressure will follow this pattern as the mitral valve is open and the ventricle sucks in fluid from the atrium. The aorta is isolated from all these events behind the closed aortic valve, and ultimately what we'll see here is passive flow from the aorta to the systemic circulation as that initial elastic recoil is now complete. Now recall that this passive filling phase is the most contributory to left ventricular filling, so during this phase we'll see a great increase in LV volume. We also may hear an S3 during this phase, which may represent the tensing of the chorda tendineae and the mitral valve ring as blood sloshes in from the atrium to the ventricle. While the S3 heart sound is often normal in children, it's considered pathologic in adults, and it's often associated with ventricular dilation and or congestive heart failure. A mnemonic to remember the auscultation that we may hear for an S3 is sloshing in, versus the normal lub-dub as blood from the atria sloshes in to this dilated, failing ventricle. Let's bring this discussion now over to our diagram. Initially, the mitral valve will open, and this will cause a rapid drop in atrial pressure as blood moves quickly from the atrium to the ventricle. This is known as the Y descent. We'll then see a gradual increase in atrial pressure as venous return passively fills the atrium. The ventricle will have a similar pressure curve as it mimics the atrium across the open mitral valve and sucks blood down from the atrium. Aortic pressure will gradually drop as blood passively moves from the aorta to the systemic circulation. We should note that the elastic recoil phase of phase 5 is now complete. We'll also see here that there's rapid filling of the left ventricle, and should remember that most of the filling happens during this stage, as the atrial kick from phase 1 only provides roughly 10% of LV volume when the body is at rest. We might also hear a pathologic S3 during this phase, which provides that sloshing in auscultation pattern. Now, phase 7 is a continuation of phase 6, and it's not easily demarcated, so we'll see continued gradual increase in both atrial and ventricular pressure, and we'll see gradual drop in aortic pressure. We should note, though, that in this phase, the ventricle is now stiffer as it's more full and less compliant, and thus that higher left ventricular pressure causes a slower passive filling. So now that we've completed our Wigger's diagram, we should note that systole is between the beginning of phase 2 and the end of phase 4, and occurs between the sequential S1 and S2 sounds. Diastole is marked out as all of the other phases. Now let's go through some final principles about the cardiac cycle. The first thing to note is that if we were to measure the pressures on the right side of the heart, we would see similar tracings to what we see on the left side, just at lower values, and this was mentioned earlier. In addition, we can actually observe these pressure tracings by doing procedures such as catheterizations, in which we can directly measure pressures on both the left side and the right side of the heart. Additionally, if someone has elevated right-sided pressures that transmit through the right atrium, we can actually see those go all the way back into the jugular vein, and that's known as jugular venous distension. If we were to observe the changes of the waves and the motions of the waveforms, we could get an understanding of the patient's underlying physiology. Now let's just quickly remind ourselves of the pressures in the heart. The right atrium is typically at 4 millimeters of mercury on average, 25 by 4 in the right ventricle for systolic and diastolic pressures, 25 by 10 in the pulmonary artery, 8 millimeters of mercury in the left atrium, 120 by 8 in the left ventricle, and 120 by 80, which we will recall is normal blood pressure. Additionally, there are a couple other things that we can pick up from our diagram. The difference between that left end diastolic volume and the left ventricular end systolic volume is known as the stroke volume, or SV. And we can actually take that stroke volume and divide it by the left ventricular end diastolic volume to get the ejection fraction. Now some final thoughts about cardiac output. First, the definition of cardiac output is heart rate times stroke volume. Heart rate is measured in beats per minute, and stroke volume is measured in milliliters per beat. That corresponds to milliliters per minute for cardiac output, which makes sense. Now, we can normalize this measurement for cardiac output between different individuals by dividing the cardiac output by body surface area. That's known as the cardiac index. Now, we might expect, if we were to double the heart rate, a corresponding doubling in the cardiac output. However, this is not necessarily the case, as, for instance, if we were to increase the heart rate by twofold via pacing, we would actually get a corresponding decrease in stroke volume, and that's because there is less time for diastolic filling during this phase. So ultimately, if we were to see a doubling in heart rate via pacing, we would see a decrease in stroke volume due to less diastolic filling time, and thus a increased cardiac output, but not twofold increase in cardiac output. On the other hand, if we were to double heart rate via a process such as exercise, we would also get an increase in stroke volume. Those together would lead to a doubling in heart rate, a increase in stroke volume, and a more than twofold increase in cardiac output, and that's because of the increased sympathetic activity that happens during exercise. And this concludes our discussion of the cardiac cycle.